Afternoon. So my name's Dr. Emma Stansfield. I'm a consultant that works at University Hospital Birmingham, and it's great to be here at this webinar today. I've been asked to do this on behalf of one of my colleagues, Dr. Catherine Barber, who's unfortunately not able to be here today. So what we know already, as Chris has already said, childbirth in the UK is as safe as it's ever been, but it can bring with it more than a morning sickness and fatigue. It can also bring preventable pregnancy-related venous thromboembolism. While the absolute risk remains relatively low, about 2 in every 1,000, the risk increases 20-fold in the 12 weeks after delivery before dropping back to normal. VTE risk factors can be hereditary or acquired, family history of VTE, age, obesity, immobility, and complications such as preeclampsia. There's operative reasons. Cesarean section delivery can increase the risk significantly. Also, prolonged hospital stays or complications during an emergency delivery. As we're all aware, the pathophysiology is that naturally clots occur more often during pregnancy, and to lessen the blood loss during childbirth, we do want to find mechanisms to try and prevent clotting. Later in pregnancy, patients may experience less blood flow to the legs due to pressure on the blood vessels in the pelvis by the growing baby. Therefore, we do need preventative strategies to stop VTE in our pregnant ladies. We need to take into account potential adverse effects on the fetus, clinical evaluations for the risk factors as mentioned above, and optimal use of both mechanical and drug prophylaxis to prevent VTE. So current standards of care. As Chris touched on, in maternity care, there is a reluctance to overuse drug prophylaxis in patients assessed at high risk of bleeding. Intermittent pneumatic compression also has tolerance issues, decreased patient mobility due to wires and leads, making it a very non-practical option, particularly during induction of labour. Also, most of our units probably only have one of these devices on them due to expense. So our decision was to embrace the geko device. We used the Barnsley real-world data influence to our decisions, and we saw the geko device in the same way as Dr. Folsey did as an innovative alternative mechanical anti-stasis intervention when standard care cannot be prescribed. We used their data set and cost analysis, which meant we didn't really need to repeat their work. We could do a quick tolerance evaluation with the sample devices in our department, and then engage internal stakeholders to make a business case for the purchase. So we're using the internal stakeholders, making the case for this purchase. GNN helped us compile this. They provided a pre-populated business case template. We simply added our own local numbers for cost-saving calculations. Along with the business case template, we included the Barnsley clinical health economic data, the NICE guidance information, and protocol for use. GNN also provided guidance on adding geko device to our drug chart. Internal stakeholders included governance and procurement, and importantly, GNN provided geko device user training. The training is competency-based, RCN accredited, and it provides CPD points. The reason that we wanted a change in practice is we is now routinely used in a maternity unit is because of events that have happened over the last few years in our department. It is prescribed when pharmacological and IPC is contraindicated or impractical, and all high-risk patients now can receive pregnancy-related blood clotting prevention where previously only mechanical prophylaxis could be prescribed. NICE guidance recommends the use of geko devices when drugs or IPC cannot be prescribed, and now Birmingham Hospital NHS Foundation Trust is aligned to NICE guidance. Thank you for listening. I think I'm staying around to the end, so if anyone has any questions about our experience and what we did and why we changed our views, then I'm here to answer some questions at the end.
Thank you very much, Dr. Stansfield, for sharing